Hello, welcome to today's webinar, Hydromorphone for Opioid Use Disorder, Insights from the Feasibility of Opioid Injecting Trial. My name is Jake Dizard. I am the Senior Research Officer here at Penington Institute. We are a not-for-profit organization focused on supporting cost-effective approaches that maximize community health and safety in relation to drugs, including pharmaceuticals and alcohol. Today, I am speaking from the never-ceded lands of the Wurundjeri people of the Kulin Nation, and I pay my respects to elders past and present. I would also like to acknowledge the traditional owners of the multiple lands from which our panelists are all speaking today. Today, we have a great panel to speak with us on a very important and somewhat controversial topic. As many of you know, Australia has lagged behind some of our global peers in diversifying pharmacotherapy treatment options for people with opioid use disorder, even though we know there's a persistent subset of people who use opioids whose treatment needs are not met by currently available options, mostly meaning methadone and buprenorphine. Last August, we at Penington Institute actually released a comprehensive report titled Opioid Pharmacotherapy at the Crossroads, which you can find on our website. And one of our policy recommendations was that governments and key stakeholders, quote, governments and key stakeholders should work together to rapidly accelerate and expand trials of alternative opioid pharmacotherapy medications, including short-acting injectable opioids, which includes hydromorphone. The reason we said accelerate and expand rather than begin trials is that, fortunately, one supervised injectable opioid treatment trial was already underway in Sydney, and we are delighted to have this excellent group with us here today to discuss the workings of the trial and share some of their observations. So I will ask each of the panelists to introduce themselves at the beginning of their talks, but just as a summary, we have with us, in order of their presentations, Dr. Craig Rogers, the Senior Staff Specialist in the Alcohol and Drug Service at St. Vincent's Hospital in Sydney. Maureen Steele, Consumer Participation Worker, also at St. Vincent's in Sydney. Dr. Jake Rance, Research Fellow at the University of New South Wales. And Anna McVinish, Clinical Nurse Consultant at St. Vincent's Hospital in Sydney. Thank you all so much for being here. Today's webinar will run for 1 hour and consist of panelist presentations followed by a bit of time for audience Q&A. I encourage you to use the Q&A function to ask questions at any point throughout today's discussion, and towards the end, we will try to get to as many as we can. Also, a reminder that this session will be recorded and accessible on our website at www.pennington.org.au. With that, I'll turn it over to Craig, who will get us started with some background on the trial. Craig, the floor is yours, including any introductory words about yourself you'd like to give.
Thanks, Jake. Hello, everyone out there. As Jake introduced me, I'm one of the senior staff specialists at St. Vincent's in Sydney. I've got a background in general practice and have been working in the Darlinghurst area since late 90s, and in particular Kirkton Road Centre. It's the late 90s. So spent many years there before being at St. Vincent's over the last 10 years. This has been, I guess, not career ending, but a nice way to round out, I guess, my work in this area in sort of one of the sort of, well, not so new, but new to Australia in terms of treatment. And look, I think I can speak on behalf of all the panel that we're very honoured to be speaking at the Penington Institute, which I guess has been at the forefront since the 80s of introducing sort of rational debate and promoting sort of new treatments, particularly in HIV/AIDS and with people who inject drugs. So let's go. Here we go. So you may have heard this trial called the FOPIT trial, which is the Feasibility of Opioid Injection trial. Its proper name is Implementation of Time-Limited Parenteral Hydromorphone in People with Treatment-Resistant Injecting Opioid Use Disorder. Safety, feasibility, acceptability, and cost. But yes, more affectionately known as FOPIT. Next slide, please, is acknowledging that I'm on Gadigal land, as I think some of my participants in the presentation are, and pay my respect to the elders past, present, and emerging. So the background for the trial was developed many years ago, and we know that Australia does have a fairly well-developed OAT system, but not all individuals respond. Work done by Nicola and Ciris, late 2000s, showed that about 5 to 15% of people engaged in treatment continue injecting street opioids and experience serious harms. But the background to this study really came from the Injecting Centre in Sydney, and various surveys that they'd done showing that about 10% of clients who'd visited there in 2017 had actually registered with the service when it opened in 2001. So indicating prolonged injecting opioid use. Similarly, a survey done that year also found 43% of their respondents were currently on methadone, or 35 had been on methadone previously, so higher than that other study. So it's not a new treatment, as we know, but it's considered what they call a second-line treatment for those who persist injecting opioids. Generally involves prescribing either pharmaceutical heroin or hydromorphone for people who persist with injecting despite access to treatment. In different studies, some people have had oral methadone, others haven't, but generally having some sort of other OAT prevents withdrawal during interdose intervals, depending on how frequently people are offered the injectable treatment. Injecting opioids are actually more rewarding than OAT. I mean, we can sort of see that instantly in some people, and therefore maybe attract people to treatment and maybe hold them in a structured treatment like OAT, when methadone or buprenorphine haven't been effective for them before. So an extra carrot, really. It's not a new idea. Next slide has actually quite a few slides. So, oh, no, go back. So the first time this was actually, many people will probably know that this was first discussed in the late 90s, mid to late 90s. ACT heroin trial was proposed, but not allowed to proceed due to the government at the time. Next slide. Then the Swiss were the ones, those clever Swiss, who started the first randomized trials of heroin maintenance programs. Many people know that heroin was available as treatment in particularly the UK and maybe other parts of Europe, but then sort of became quite limited to certain doctors working in addiction medicine. So the Swiss did the first randomized controlled trials. Then the two sort of bigger trials were done in the in North America, namely Canada, called NAOMI, North American Opioid Medication Initiative, and then the next major study was the RIOT trial in the UK. We know that this sort of has worked. The next point, though, is that these earlier trials are all with diacetylmorphine or pharmaceutical heroin. The Canadians also did a small pilot study in their NAOMI trial of using hydromorphone, and I think it was about 25 participants, and they couldn't sort of really tell the difference between hydromorphone and diacetylmorphine. So a larger trial was sort of done to sort of see if this could be another feasible option, and they did sort of show that this could be done. So that sort of led the way for us to maybe do something different to what was posed before. Next slide, please. So why this sort of program? So while other studies have looked at the effectiveness of injectable treatments versus methadone, we're not doing that necessarily. They haven't actually sort of looked at time limited. So they've often been 6 months or 12 months, and then some people have had options to continue therapy and others haven't, sadly. But a lot of these studies have shown that often the most benefit occurs within the first 6 months of treatment, and then things tend to stabilize. So looking at sort of some of the earlier studies, some other sort of cohort studies, it shows that maybe moderate term injectable treatment with transfer to methadone may be more effective use of resources, because that's always a concern when rolling out programs like this. So FOPIT participants are offered injectable hydromorphone, parenteral hydromorphone, as an adjunct to methadone or potentially other agonist treatment, as it sort of turned out some of the participants were on, for up to 2 years, 24 months, followed by transfer to standard methadone or other agonist treatment, and maybe even depot treatments if that's what people want. So, as I said, this was sort of spearheaded by Uniting and the Sydney Medically Supervised Injecting Centre. It was hoped that this would be conducted in a standard opioid treatment program, and Vincent's being the nearest were approached and agreed to participate. And then because of the, I guess, the qualitative aspect of a lot of the research, University of New South Wales will also have come along as partners. These are our main investigators, and then our associate investigators, which I'm sure people will know many of those names. What we're lucky to have, though, in our associate investigators, like Professor John Strang from the UK, Professor Wim van der Brink from the Netherlands, and Professor Eugenia Oviedo-Lopez from Canada as our associate investigators who helped guide us. And James Bell, Nick Lanceris have all had experience with DIOT in the UK. Next slide, please. So it's a single site done at St Vincent's Rankin Court Treatment Centre, done controlled, open label so people know what they're getting, aiming to recruit 20 to 30 people who are still injecting opioids while on OAT or not on OAT. And they're offered injectable hydromorphone, including oral methadone for up to 24 months. At the end of the 2 years or sooner, as we've sort of seen for some people, and they've transferred to either methadone or other treatment, we then will interview people 3 months after that to sort of see where they're at. And maybe next point, so we've talked about that. Oh, actually, sorry, the last point there. So what we're looking at mainly is the feasibility of this in the Australian setting. Can we do it? And I'll talk a bit more about how we measure that. Safety and cost are also other factors, not cost effectiveness. We're just assessing the cost, and so that if other people are going to take this up, that they'll have a bit of an idea of what cost they're looking at. Next slide, please. So the primary objective, feasibility, which is acceptability to participants and also staff, and also some non-participants. And we assess those in qualitative interviews, and also by looking at their participation in treatment, so recruitment, retention, dosing, and then potentially ongoing OAT treatment following the cessation of injecting treatment. The secondary objective is safety, cost, changes in various levels of drug use, quality of life, mental and physical health, social connectedness, and crime. Next slide, please. So I guess the novel aspects of this trial is that, one, we're introducing injectable treatments into Australia for the first time. And I think, as I mentioned at APSAD, whoever does this next, it's going to be a lot easier for them because we've got a model of care ready to go. Look, it's an interesting treatment, and certainly being in a public hospital setting, having come from settings such as Kirkton Road Centre and working at the Injecting Centre, very different bringing this into a mainstream hospital-based service. And yes, there's anxiety in staff who are very hospital-centric, certainly administrators, politicians, and many other stakeholders. So if we can, show that this can be done effectively, safely, then hopefully we're going to decrease that anxiety. And, we can sort of demonstrate how the participants are experiencing positive changes within the trial. Next. So the other important thing that that people wanted to show in this trial, that it could be done in an existing OAT clinic. So, which, I mean, we can have wonderful services like injecting centres, a lot more money to establish. But if we have OAT clinics where this could be done, it's going to be able to sort of save some of those resources. That hasn't come with its challenges as well, of working in a major hospital where overdose really isn't something that major hospitals want. So I'm sure Anna will talk about that a little bit more in her talk. But we've been lucky that the team at St Vincent's have been working alongside us to try and come up with the best ways to deal with that. And, the nursing staff will be able to sort of cover both traditional dispensing and injectable treatment roles. It is an expensive treatment, involves coming twice daily. Preferably people, it's better that they live in the proximity of these services. So if they could be in sort of more local OTPs, so that would be better for the participants. Next slide, please. And so the other novel aspect of this is, and which is often a little bit controversial, is that it's time limited to 2 years with the objective of transfer to conventional OAT. So the idea is that this is a period of intensive treatment to try and interrupt the sort of long-term pattern of injecting and involvement with sort of illicit drug use. So hopefully people can experience the possibility of positive change and being a little bit more in control of their drug use or their opioid use, and to sort of be able to sort of plan more effectively about what they would sort of potentially want to do. And some studies have actually sort of shown that people, you know, if they're given indefinite access, may never stop injecting. But I guess this, as I said, this is a novel aspect and is what we're sort of looking at. Next slide, please. So we plan to recruit during 22 over 6 months and recruit from injecting centre primarily, but also from the local OTP service, Rankin Court, where I work, and other local services. Next slide. Aiming for between 20 and 30, that's okay. And people who drop out could have their place kept open for 3 months. Next slide. Inclusion criteria are between 21 and 60 years of age. I guess the cutoff of 60 was sort of decided in that with sort of increasing years, more health issues potentially could occur. I mean, I wouldn't necessarily say the treatment needs to be limited to people below 60 because I'm very healthy over 60-year-olds, but for the purposes of the study, that's why that age group was chosen. Minimum of 5 years of opioid dependence and physical dependence on opioids. Previous access to treatment and currently injecting opioids at least more than 3 times weekly. These are all self-reported as well. We sort of can go digging for too much past history, but with a lot of the referrals coming from the injecting centre, we're fairly confident about previous access to treatment and injecting history. Evidence of harm from opioid use, such as listed there, being able to provide informed consent was important. That's okay. Exclusion criteria, fairly standard. So pregnant breastfeeding, advanced liver disease, and serious chronic airflow limitation. These were sort of assessed in the medical assessments and any other sort of severe or active medical condition that would be difficult to treat, and or that giving somebody potent opioids might be disadvantageous. Next slide, please. Same with I guess mental health issues. Severe active mental health issues were excluded, but say if somebody had schizophrenia on treatment within a treatment team, then that would be okay. Next slide. And just cognitive impairment and inability to provide informed consent. Even if the English was not the first language, that was, I guess, too difficult because in terms of overdose, it would be hard to sort of deal with that in that sort of setting. All right, general care. So people, when they're in the program, we sort of peeled back a lot of the sort of requirements of the study in that rather than sort of seeing a doctor every 2 weeks, really, I mean, they sort of do because I'm there every day almost. But for our regular routine reviews, it's every 3 months like you would in a normal OAT setting, but more often if need be, and meeting with care coordinator regularly. So we actually recruited in that time frame about 69 people expressed interest in coming onto the trial. 53 underwent pre-screening with a trial nurse, and ultimately 22 participants came onto me and screened and eligible. We struggled a bit with the space that we had and staffing. So getting beyond sort of 22 in the first few months was really difficult. It would have been nice to have more people, but that has limitations of space. And I guess with if anybody else is going to take this on, we're very happy to advise on those aspects. We hopefully have a broad range of people, participants. So age ranges from 28 to 59 with an average of 46 years of age, which is fairly standard for OAT services. Similarly, the distribution between male, female, and transgender, fairly standard. We had 9% of people identifying as Aboriginal and 36% as identifying as either LGBTI. At enrolment, about 68% of people were already on OAT, 90% methadone, 1 person on Suboxone, and 1 person on Buvidal. Some of these people who are on methadone weren't necessarily picking it up very well. They were at pharmacies and not necessarily taking their takeaways. So we'll sort of tease that out a little bit more in some other data later on. So from a conclusion, we were happy sort of, I guess, with the amount of people that we recruited and expressing interest. A lot of trials that have been done have found difficulties recruiting participants. Some of them might have been stricter entry criteria, again, limited clinical capacity, or sometimes too clinical. particularly in the Netherlands. Often the trials there was smoking, and that I guess is more suitable to a nice, relaxed environment, as in is injecting, I guess. But yeah, it does become very clinical after a while, and also chasing up people again. In this group, sometimes we know it's very difficult to catch up to people. Other studies where there've been long sort of lead times into sort of being recruited has also involved loss to follow up. So we're happy. Relative recruitment was relatively easy. We feel that there's a need and a demand as a second line treatment for people who continually inject illicit drugs. I think that's my last slide. Yep, there we go.
Great, thanks for that excellent intro, Craig. Next, we'll hear from Maureen Steele, who will introduce herself very briefly and share her perspective on consumer issues.
Thanks, Jake. So just to let you know who I am, I've been working in the consumer space for a while now. I started working at Newer in 1992, involved in a lot of advocacy work around drug treatment. Probably my claim to fame was being involved in getting biodone into Australia, into Rankin Court back in the late 90s. After that, I worked in the NSP program for a while and up at Sydney MSIC. And then I came to work at St Vincent's around 7 years ago now in a consumer advocacy role. Very new in the drug and alcohol space. There sort of aren't many of us working out of hospitals. So that was an interesting experience. In the last month, I've gone to work for the Ministry of Health in the first lived experience position. But I'm still involved in the FOPIT trial, which I'm really excited about. So to get on to my first slide, a bit of background. There's increasing recognition of the importance of consumer involvement in research, but there's also a lack of clear processes to facilitate consumer involvement. So I'm going to be talking a little bit today about the recruitment and establishment phase that I was involved in. So next slide. Just want to let you know what I actually did, what my role was in FOPIT. Before the trial commenced, namely me, the consumer participation worker, I attended most of the steering committee meetings and the other meetings as appropriate. I actually spent a lot of time reading the manual of operating procedures and reading different iterations of that and commenting on that. And also reading over any FAQs and client information forms, the consent form, the patient information form, making sure all that was in plain English. During the recruitment phase, I spent a long time talking to potential participants about their expectations and what their goals were. We had a couple of consumer meetings as well to talk to people about what the trial was all about. An important thing, I think, was engaging people who were not participating in the trial. There were a lot of people at the clinic who didn't apply or weren't accepted, and talking to them was an important part of my role. Next slide. I also gave a lot of support for FOPIT participants, the people on the trial. Basically, I spent a lot of time in the waiting room. Consumer workers do that a bit. It's a good way to engage with people while they're waiting, in a sort of casual kind of way. So I spent a lot of time in the waiting room talking to the FOPIT participants. We also held 3 consumer forums during the trial to talk about issues as a group. I attended all the relative kind of clinical meetings, and then I continued to have consumer meetings every 3 or 4 months with consumers. Attendance at those meetings did fluctuate as I suppose people got used to the trial and got established. Attendance at those meetings did sort of start to wane off a bit. No, I suppose not everyone wanted to engage with me. I think this is an important point to say. I think some people take it for granted that everyone will talk to the peer worker, but obviously not. Not everybody trusts me. Why would they? So, my relationship with participants sort of, depended on the people. Even though obviously I tried my best to engage with everyone, I suppose some people are just, they don't want to engage, and that's fine. Next slide. This is just a little bit about the process of working with consumer workers. Basically, I feel that my role was an essential part of the trial to assist participants to feel welcome, to answer their questions and navigate their problems. Also, managing expectations, I think, was a big issue. It wasn't always easy, especially things around the time-limited nature of the program. And then, as I already said, I was also there to support people who were not accepted onto the trial, as well as the other consumers who were continuing to attend the clinic for their methadone and their bupe. Those people needed a sounding board as well. Next slide. So I just wanted to go through some of the issues that were raised. And like I said, I'm mostly talking about the recruitment and establishment phase of the trial. We sort of results are to come yet. So these are some of the issues raised by clients who thought about doing the trial and then decided not to apply. First of all, they pointed out it takes too much time. Coming in twice a day, especially if you lived a long way away, was obviously a big deal, as Craig already pointed out. And it also included waiting time while you waited for your turn and observation time after you had your injection. Some people felt that they shouldn't get on the trial if their personal goal contradicted the program. So, for example, some people felt, hey, this would be a really nice 2-year break from what I'm doing, and I really could use a rest from what I'm doing. But, you know, I might go back to drug use, injecting drugs afterwards. So if my goals are different to what you're saying, you really want me to establish on methadone, should I go on this trial or not? Another issue was one of the guidelines for the trial was you're only able to inject in your arms, or if you don't have any spaces available in your arms, you've got to inject intramuscularly. And for a lot of long-term injecting drug users, their veins in their arms are long gone. A lot of the European people who were on injectable opioids were saying that IM seemed to be pretty good. They liked it, but I don't know. In Australia, IM injection is not something many drug users do here. And I think they were kind of naturally a bit adverse to the idea, even though some people did inject IM in the end. Some people ask, well, you know, why do we have to take the methadone? Pointing out that maybe that'll give you a further tolerance to hydromorphone. If you get no effect from the hydromorphone, what's the point? And other people ask, why can't we take it home with us and not take it under supervision, which obviously is part of the model of the trial, and that just was never really an option. It's not the British system. Next slide. So this was issues raised by clinics, so the attendees at the clinic not interested in being on the trial at all. And they kind of fell into 3 general responses. If this trial doesn't impact me, then I really don't have an issue with it. A lot of people felt that way. And I would say the second point, the majority of patients were really supportive of this trial. And some people were even proud that it was happening at their clinic. And they were supportive of their other community members doing well out of it, which I thought was great. A small number, and I was in this group, felt that they might be triggered. Why couldn't it be somewhere else? And that knowing people were injecting in a room over there could be triggering for me. Next slide. So this was the issues raised by clients who were not accepted onto the trial. Managing the expectations of these people were obviously a little bit more difficult. You know, being not accepted is always upsetting. Probably the major issue that people raised, they felt there was a long delay to be told that they were not accepted. And then there were complaints about the actual criteria issues. Things like a nil psychiatric acuteness. I suppose people were questioning what does that actually mean? And yeah, I couldn't always answer that. Another point people make were that you shouldn't, similar to the last point, we shouldn't judge us on our prior mental health presentations and rather on our current presentation. Again, this is sort of how consumers were seeing things. I'm not sort of implying for a moment that clinicians were doing this, but it's sort of how people felt. I think a lot of consumers basically didn't see the trial as participating in research, but as a form of treatment. And I think that's another big barrier. You know, even though we're saying this is a research project, it's hard for participants to see the difference. For them, it's their treatment. And talking to researchers is sort of like an extra duty that I think most people are fine as long as they're getting paid with it. But sometimes it can be hard for people to understand that this is a research project and how that differs to a permanent service. Not too sure if I explained that very well. Anyway, my final point was the point about people being under 60. It's an ageing population, and there were a lot of people over 60 wanting to be on the trial. As Craig pointed out, it's just one of those things about trials, having an age limit, because as you get older, you might have more health issues. Next slide. So what are the next steps and the implications for practice? Like I said earlier, I can't engage with everyone as a peer worker. While the idea will be to continue to engage, and I am actually going to be involved in the wrap up of the trial, it is hard for one person to engage everyone. And also, I suppose my final point really is, can consumers expect service delivery to change during a research trial? Well, not really, because the protocol is a reset. You know, ethics can be changed if the issue is a real deal breaker, but the way research is set up, often as a consumer, I'm sort of involved in it later in the piece, and there's not an awful lot that can be changed once things are sort of set in stone. And that's about it from me, I think. So I'll pass over now to Jake.
Two Jakes, actually. Thanks a lot, Maureen. That was a very interesting and important set of issues to think about. And on that note, I would just remind everyone quickly that you're welcome to type in any questions you have, because there's a lot of interesting angles emerging already here. And so anything you want to, ask people to maybe follow up on a little bit, you can type them into the question and answer bar, and we'll get to as many as we can. Next up, we have Jake Rance, who will discuss the motivations of trial participants. You're on mute still, Jake. We're missing your introduction, I believe.
Hi, everyone. My name is Jake Rance. I am a research fellow with the Centre for Social Research and Health at UNSW. Been there for about 15 years, but like Craig, I sort of kicked off my AOD harm reduction career working at Kirkton Road. So I actually joined Kirkton Road during the May 1999 drug summit. So yeah, I've been kicking around for a while, and like Craig said, it's kind of been a joy working on FOPID and working not only with the participants but people I've known for a long time, like Craig and Maureen. First slide, please. Next slide, please. Next slide, please. Right. So one of the primary aims of FOPID is to evaluate what we're calling the acceptability of both the supervised injectable opioid treatment, so injectable hydromorphone, and its service model among participants. So understanding why people decided to participate establishes important context and background regarding this acceptability. It's worth noting here, as Craig pointed out, that international trials of injectable diamorphine treatment have typically struggled with recruitment. Often fears or assumptions around free heroin acting as a honeypot or somehow undermining other opioid treatments have in fact not been borne out. And while Craig pointed out FOPID didn't struggle with recruitment, it's just worth noting that it's not necessarily a given, despite what people would assume around injectable treatment. Just a quick note about qualitative interviews. So the qualitative interviews we sort of typically understand as something of a kind of joint accomplishment or a co-construction between interviewer and participant. But it can also be understood as what we might think of as a moment in identity work for the participant, a practice of self-formation, if you like, where the individual who's being interviewed is effectively invited to sort of find, shape, and describe themselves, to account for themselves. And during the baseline interviews for FOPID, this was particularly evident where, most people at baseline interview, they just started the trial by definition. They maybe had injectable hydromorphone on 1 or 2 occasions. And then I'm sitting there with them, asking them to think about what might be their goals, what was their rationale for joining FOPIT. And, you know, for some participants, not everyone, but for some participants, clearly the research interview became this sort of opportunity for a kind of a thinking through, or almost a thinking aloud. I remember one particular participant, Ava, talking about what she thought might be her goals, and then suddenly declaring, actually, that's it. I think I've established a goal. I think I've set a SMART goal, measurable, etc. How achievable? I don't know. But the point is, I think the interview process in a way helped establish, for some people anyway, an opportunity to think through what were their goals. They may have had some of the rationale well established, but for some people, it was a sort of work in progress. Next slide, please. So the qualitative data we're collecting as part of the research evaluation comes from a set of in-depth semi-structured interviews, 15 at baseline, 15 mid-treatment, and then 15 at the end of the trial, so yet to come. Certainly for the baseline interviews, the average duration of interview was about 15 minutes. One was pretty brief. A couple went long, about 85 minutes. And how they worked was everyone who joined the trial, every participant was expected to participate in a number of quantitative measures. Craig ran through some of those earlier on, so crime, quality of health, those sorts of fairly standard measures. And when I met with participants and went through those quantitative measures, that was a sort of opportunity for me to establish, I guess, a kind of degree of rapport with people and ask if they would also be interested in participating voluntarily in a qualitative interview. And I have to say, there was only one participant, I think, who was consistently kind of refused that over the first 2 sets of interviews we've done. Obviously, you know, my talk today is incredibly, gives a very brief sort of overview of just 4 participants. I've tried to include the 4 are a mix of gender identification, sexualities, several worked, several unemployed, several were in government housing, one in private rental, one person was homeless, and a variety of treatment histories. Next slide, please. So our first participant, Nino. Nino had been a long-term drug user advocate who was interested in the trial for his own reasons, but also interested in the broader politics, I guess you could call it, of the trial. Nino had no aspirations to necessarily stop using opioids. For him, he described opioids as enablers, and he'd been a long-term, he'd been on methadone long-term. So when I asked Nino about, you know, when asked about the trial, Nino said, I wanted to get onto the trial as soon as I heard about it. And when I asked him what was most appealing about FOPIT, he said, well, the thing I've always wanted, just my injection, my shot. I get 2 shots a day and they're really good quality. And I'm not going to be, you know, deported for doing it. It changes the whole dynamic. It's amazing. It changes us from being criminals to being, you know, productive members. And so when I teased Nino out a little bit more about this sense of legitimacy around the trial, around the, you know, authorized injecting of a treatment, he also went on to explain that it was a kind of vindication. In his words, the fact that we weren't wrong about ourselves. I always thought that if I was given the opportunity to have my injections without the legal concern, you know, freely, that my life would be stable and great. And it is. Next slide, please. Simon had a long, as obviously did some of our other participants, had a long history of abuse. He talked about heroin for a long time functioning as what he called a good antidepressant. He described heroin as definitely saving his life. In Simon's words, he explained, "I found with heroin, I was still able to be normal. I could still do things and it didn't look like I was freaking out. You can still fit in. As long as you're in that threshold of not being too smashed, you can function." And that was historically. Obviously, by the time Simon got to the trial, you know, years of having to negotiate in a criminalised market, etc. As he said, "I'm running out of options, really, with treatments. I'm on the verge of homelessness. I can't afford to be spending nearly $1,000 a week on heroin. This gives me the opportunity to at least take a step back, to breathe." He went on to say, I'm relying on this, i.e. FOPIT, to help me be the person I want to be, so I can be good for her," meaning his partner too. I'm hoping my self-worth will get a lot better doing this because I'm not doing the heroin and stuff. There's actually a lot of things I'm hoping I'll get out of this trial. And I should say that this person, Simon, was the only participant who'd actually had any prior experience of hydromorphone. And that was a consistent finding, actually, that despite the breadth of experience amongst all our participants and long histories of use, there just was no familiarity at all with hydromorphone. A few of the older participants had heard of dilaudid, but hadn't had actually any experience of it. Next slide, please. So Billy was someone who had been long-term user, was one of our older participants, and unlike most of our participants, had only had a very short period on methadone. Didn't like methadone. Had had a brief period on bupe, but had found that hadn't worked either. And Billy was probably the first person, to explicitly refer to the ACT heroin prescription trial back in the 90s. So this is what Billy said about the appeal of hydromorphone. "It was a heroin substitute, an injectable heroin substitute. Amazing, you know, it's just the best thing I could imagine. Like, we thought this was going to happen like 20 years ago, and it was so disappointing that it didn't." And in fact, it was really interesting hearing Billy had actually found out quite tangentially about the FOPIT trial and took some convincing that it was actually going to take place, because she said, unlike the heroin prescription trial of the 90s, there had been no talk at all on the streets about FOPIT. And so it took some convincing for her to realise it was actually a real trial and not just someone having a lend of her. She went on to say, I'm getting old, too old to use really, and no veins, but I just couldn't bring myself to go on methadone. Next slide, please. Luna, once again, found out almost by happenstance about the trial. She they were presenting for methadone at Rankin Court and was told about the trial. She describes herself as being totally blessed that I got on it. I really wanted to just try almost anything to stop the destructiveness in my life, the day in, day out, personal and psychological and physical destruction of my life through using heroin. I don't think of it, i.e. FOPIT, as like a shot of gear. I just see it as part of the methadone program that I'm on, and that it is keeping me off heroin. And her aims to stay clean and sober and not have to do crime and not have to feel guilty and shitty, because that's how it makes you feel sometimes when you're using. So I'm slowly feeling like I'm part of society again. And I would say with Luna and a number of other participants, whilst the hydromorphone was obviously a key part of the attractiveness of the trial, there were other dimensions as well that weren't just about drug treatment. So for Luna in particular, she'd been homeless long term, and when she joined the trial, housing was as much a priority for her, I would argue, as trying a different pharmacotherapy. Last slide, please. So underpinning the diverse histories of all the participants, including their treatment histories, nearly all expressed a deep and heartfelt desire for personal change. Personal, but also relational, familial, financial, social, and so on. For some, FOPIT also afforded hope for progressive collective change. There were a number of clients who, as Maureen and Craig noted, people were proud to be part of FOPIT, and they were well aware that this was a trial that was not just something that they might personally benefit from, but also a possibility that others would benefit from, and that it could be about collective progressive change. My sense is that hopefully by trialling something new and novel in the context of the Australian opioid treatment landscape, FOPIT not only catalyses important pragmatic shifts within the existing system, but more broadly, I hope, in terms of how we think about people who use opioids and about the notion of treatment itself. Thanks.
Thank you so much, Jake. Really illuminating client observations in there. So finally, we have Anna McVinish, who will briefly introduce herself and talk to us about the clinical model and the role of nurses that was applied during the trial.
Thanks, Jake. I actually can't see my slides. I don't know whether I've got a buggy Zoom situation going on.
Anna, you might want to just try sliding a little bit. You look like you're in the witness protection program.
I don't know. So buggy. I don't know why that's happening. I'm actually super close now.
Okay. Well, we can see your slides.
I'm not in witness protection. So I'm Anna McVinish. I'm a clinical nurse consultant working at St Vincent's in the Alcohol and Drug Service. I was the implementing nurse unit manager for the study and nurse clinical lead at the establishment phase. And yeah, I'm immensely proud to be here with my remarkable colleagues, talking to everybody today. Next slide, please. First slide, I'm just going to run through what moving through the clinical space looks like. If Reese, you're happy to kind of tap through, there's a number of points here. So first, coming into the clinic, I understand this looks different in Victoria, but coming into a public OTP clinic to receive one's methadone or buprenorphine is the first step. Get that dose, that administration of that said dose is confirmed by the FOPIT staff. Study participants would then come out of the Rankin Court space around back into the shared waiting room, which, as Craig mentioned, is a really interesting thing for further unpacking in future, I hope. Then over to the FOPIT side, where baseline observations are measured, a sedation assessment's undertaken, both by nursing staff and by self-report. Medication is then prepared by 2 RNs. A third RN sits in the injecting area, who directly observes that self-administration and provides vein care, for example. Then 5 minutes post-dose observations are measured again, and a repeat sedation assessment, again by nursing staff and self-report. Participants then move out of the injecting area into the shared waiting room again, which is an opportunity for aftercare, tea and a biscuit, a conversation, etc. And 15 minutes post-dose, a visual sedation assessment is undertaken by nursing staff, which gives clearance to leave the space going forward. And before we move on from this slide, I just wanted to emphasize, as each of my colleagues have in different ways, the duration and intensity and how unique that is. So I did a calculation that if all going well, there's no one in the queue, you might be in and out of getting methadone in 10 minutes, say. That's an ideal. You come in, you get your dose, you drink it, you go. Where for FOPIT, even after we had kind of downwardly revised some of our kind of monitoring times, that's probably a 30-minute window at least, again, on the very best day. And that's then twice a day. And so you think over the course of a week, 10 minutes, 7 days, 70 minutes, it's actually an hour a day, 2 lots of 30 minutes for each session, which is 7 hours over the course of a week. So by contrast, just the very kind of intensity to be noted. Next slide, please. Thanks, Reese. Keep going through, press again if you can. Beautiful. So here are really just therapeutic intention. So we're trying very much more than just anchor points, but values to kind of weave into the nursing practice on a day-to-day basis, which meant kind of in synthesis that we needed to really upwardly revise from that kind of lowest common denominator approach in healthcare, which was, gave us the gift as nurses, the possibility of emphasizing our relational work instead of how things can often look, and with that a kind of therapeutic generosity to speak to some of them explicitly, emphasizing dignity, including people in treatment planning, emphasizing increasing people's agency around their administration ritual, also upholding people's contribution to the research, and hoping to enhance people's treatment expectations, and the flip side of that being kind of decreasing occupational stress, the need to use unsterile equipment, for example, barriers to navigating the treatment system. Also decreasing, as Maureen mentioned, the kind of expectation that there would be an essentialist abstinence approach to what we were doing, and so giving space for individual approaches, I suppose. And I chose this image on the left side to demonstrate that. This is a piece of paper that sits on the wall in the medication preparation area beside where all of the injecting equipment lives. On the left side, blacked out, is the column where participant names are. Sorry, my nervous voice. After that comes the syringe tip preference, and then other supplies that people might like to use when they're injecting. So for example, you could say kind of like, Nino prefers the long orange, loves a butterfly, doesn't want a tourniquet, loves a Band-Aid, all of those kind of unique preferences, which are significant and important parts of that therapeutic generosity in having this be a meaningful engagement for each person individually. Next slide, please. Challenges, so many. I'm just going to speak to 2 of them in particular. The co-location in the conventional OTP, being a space that's been designed to maximize efficiency for high volume, high risk medication handling from behind a glass screen often, where, you come in and you dose and you go, lest dealers be afoot. For FOPIT, we literally mandated loitering in the waiting room and kind of expecting people to engage. And again, with that duration and intensity of engagement at very close proximity, our hands on people, measuring blood pressures, etc. It was a really significant difference from kind of how care had been undertaken in that space previously. Another really significant one being the co-location in a tertiary referral and teaching hospital. So as all of my colleagues know well, this has largely remained a challenge throughout, and I think certainly we press a lot of risk buttons initially. Concerns, and a lot of anxiety around medication storage, as an example, and I have a ton here, of having to bolt a 300 kilo safe to the ground lest it go missing, special orange bags to store the hydromorphone in, despite that being the only medication in the safe, clinical deterioration pathways and parameters that couldn't deviate from clinical emergency response policy. Clinical staff could, would, and should not administer naloxone or oxygen before escalating the deterioration to the ICU Code Blue team, who would then naturally take over management with a very different management approach. And it was mooted kind of that people would be admitted, there'd be lengthy post-overdose monitoring, naloxone infusions, etc., despite a volume of evidence, despite the fact that these kinds of requirements would not be acceptable to study participants. And yet at the 11th hour, one of the medical leads from one of the committees with whom we had negotiated at length, despite everything, despite the purpose-built space, despite a multitude of agreements and preparations, safety protocols, and again, overwhelming evidence, it was implored, can't we just move it to the ED, you know, on the basis of risk? And so it was in the context, and it remains in the context of this delicately negotiated treaty, that, again, building the relational dimensions of nursing practice became absolutely paramount in order to somewhat offset the institutional shadow. And in doing so, we hope to right some of that imbalance and the structural vulnerabilities that we know our participant cohort experiences in healthcare settings. Next slide, please. So we created for opportunities for kind of a more kind of relational engagement. As you can see on the left, bottom left, we've got for pets. So this is a poster, for example. We had another one of these with everyone as children, staff and participants alike. Some incredible photos on there, which for privacy, we won't show. But this is everybody's pets. And in that, there's something of a togetherness. Above that is a photo, and we've received many, many kind of rich photos of food prepared, where people had chosen to prioritize spending their money in different ways, prioritizing caring for themselves in new ways. Cough it, again, a kind of upholding of individual preferences, kind of how many sugars do you want, extra hot, etc., whatever, so that you could, you know, after you've had your after self-administering, that you could then sit and have a coffee and a conversation as you like it. Also making available other opportunities for engagement in the community, making those things available, incredible gifts of artwork, which I think, if nothing else, was a sign of participants being prepared to leave something of themselves in the space afterwards, you know, and it was a beautiful sense of ownership. And FOPIT's favorites, and that QR code does work, is a playlist that was created so that all participants could nominate songs that they wanted included on it, and so everyone got to hear their favorite from time to time when they're in the clinic, and we were playing music. Next slide, please. Yes, this is a tricky one, but like so interesting. So in the establishment phase, we really I have learned so much around particular polarities, and these are themes which they could be organized around, and there's lots more to think about in these, but understanding that like what was thrown into relief were really these incredible kind of differences of opinion and experience between, say, staff and participant experience. So I've just lost my note here. Here we go. I mean, it looked like comfortability, for example, with intoxication, and when levels of intoxication where staff had a different level of tolerance to what participants naturally did, or even expectations around what was kind of truthful disclosure or not, on what was privacy, and what was timekeeping, what did that mean, and kind of all of the, and what does the dignity of one's time mean even. And so there was this incredible poignant often and challenging mandate to negotiate between these polarities and to really seek to dial down the sense of threat that both kind of staff and participant cohort were experiencing kind of in this space again and again. And with that, I should add just really briefly the repair part of the rupture and repair and what that has yielded. Yeah, next slide, please. So much, but very clearly more than medication from the very beginning. Also really interesting kind of what is a nursing model, what is the model. I suppose nurses were doing a lot of the frontline delivery, but certainly without allied health, without an incredibly passionate pharmacist, without opportunities for psychotherapeutic engagement, without opportunities for kind of exploring identity, without exploring dimensions of identity that have been neglected potentially, you know, over so long, without regaining kind of like opportunities to regain roles of ascribed social value, you know, all of those things build what is really unique about this as a treatment. And so probing that more, I think, is incredibly important. What do co-design opportunities look like from the beginning? You know, what does training look like? How do we prepare people to work in this space, which is you know, acutely intimate as well as challenging, and requires a kind of a sustained approach to facilitate that, an engagement of such duration and intensity. Yeah, so again, kind of opportunity to consider therapeutic approach. What is it? Is it treatment? Is it harm reduction? Is it safe and stable to supply? Do any of those preclude the others? Do they all coexist? Stigma, staff assumptions. I've heard incredible things, incredibly terrible things at times, but also incredibly excellent things. Participants internalize stigma, also really poignant and distressing on occasion, and to address, of course, the health equity and structural factors and vulnerabilities for participants. Next slide, please. I'm very mindful of the time. This is the original clinic staff, and there is apple from the tree of knowledge right in the middle. I've been incredibly lucky to walk this journey with a bunch of boundary riders in so many ways. And the participants feature so significantly in that. I think anything that they have gained from this, and it may not be a lot for some, you know, in terms of kind of what they've reported back. There's a variation, of course, but the reciprocal return has been huge, and we are all the richer for it. It's been a wonderful experience, and thank you.
Thank you so much, Anna, and thanks to all of our panelists today. It's a really fascinating set of presentations, and I think you know, the depth of your thought and reflections on all this is really powerful. And as a testament, I think I've noticed that despite the fact that we're over time, a vast majority of attendees seem to have stayed through the entire thing, which is, you know, again, a testament to how interesting everything was here. Thanks also to the panelists for answering some of the questions that have popped up live in the chat. So people had a few interesting questions about technical aspects like dosing and tolerance, but also several people just wanted to say how glad they are to see that this is finally happening in Australia, and that they have, you know, seen experiences where this really helped people, particularly in the UK, and that it is about time that things are moving along here. So we don't have time for any additional questions, but I guess to close it out, hopefully we'll be able to have you back in a year or less, or maybe a little more, depending on how things go, and find out even more about results, next steps, perhaps all sorts of things. But for now, I'd just like to thank the panelists once again very much for carrying out this really crucial and path-breaking work. Thanks to everyone who joined us today. And just as a reminder, you can access the webinar, our opioid pharmacotherapy report, and other Penington Institute webinars on our website, and follow us on social media channels to hear about other things we have coming up in the works. So thanks once again to all, and enjoy the rest of your day.
Thank you.